Okay, doctor, it's perfect. So for about in 4 minutes, I will start the conference.
Thomas, grüß dich. Ja, weil ich bin jetzt gerade bei dem Meeting Bogotá. Das geht jetzt in 3 Minuten los um 20 Uhr mit Aufzeichnung. Egal, muss man durch. Ja, gut. Da klappt es jetzt bei dem dritten Vortrag hier dann. Okay. Kein Problem, Thomas. Danke. Ciao. Tschüss.
Well, hello.
Okay.
Yes. Thanks to all the audience who follows our broadcast. Well, we have the honor today of having Dr. Uwe Spetzga. Dr. Spetzga is a professor and chairman of the Department of Neurosurgery in Killington, Karlsruhe, Germany, and president of the German Academy of Neurosurgery. Right now, at the 2021 IWBNC, Dr. Spetzga is going to share a lecture on access roads and decision algorithms for removal of colloid cysts. Please type out your questions in the Q&A panel. We will read them after the end of Dr. Spetzga's intervention. Welcome, Dr. Spetzga, and thank you. It's all yours.
Thank you. Greetings to Bogotá. And it's a pity, but I have a presentation in the morning in Berlin, but I also sit in my computer at home. But it would be impossible to travel Berlin and Bogotá in between 10 hours. This is an advantage of the Corona pandemic, but also a disadvantage, because to visit our nice country in your nice country will be essential to grow the neurosurgical friendship and growing together in this community. I have 40 minutes to discuss with you the access routes and the approaches, and especially the decision algorithms for colloid cysts. But let me start just where I am, where I'm sitting in my hometown at the computer. It's in Karlsruhe. It's on the opposite side. Bogota is here around the globe. And Karlsruhe is in between, in the middle of Europe. And it's in the southwest of Germany. And it's called the home of justice, because we have the highest court here in Karlsruhe. They are not in Berlin, they are in Karlsruhe. Probably this will last for the next decades. And if you closely look to the model of the city, the city map, the cityscape, it looks like all the streets up to now, they center in the tower of our castle, and it's a perfect scenario for a stereotactic meeting if you closely look to this cityscape. And we also home the Institute of Technology, the former university. It's one of the biggest scientific institute in Germany. It's highly ranked. It's not medical driven. It's highly ranked in the natural science, engineering, and computer science. And two very high-ranked personalities from the Karlsruhe University, respectively from the KIT, was Heinrich Hertz, who has found the electromagnetic waves in the 18th. And you all know these broadcasts will not be possible if those electromagnetic waves were not found. And also a very famous Karlsruhe inhabitant was Carl Friedrich Benz. Everybody know him from the patent of his motor car. And this is now it looks like two of the famous KIT guys. We also have Nobel laureates, and they are affiliated, and especially the founders of the SAP, the software hub, came from the KIT. And we are also proud to have the high-end innovation hub and innovation center from SAIS here at the campus. And this is our hospital. This is the old part, looks quite ancient. And this is the new building. We just moved in several weeks ago. And if you come to Germany, come to the southwest of Germany, please give me a short mail or a phone call, and you're cordially invited to visit this hospital. And this is this complete surgical building, only with 20 new ORs and approximately 90 ICU beds. And we were very glad to have a hybrid OR in it for our neurosurgical interventions. Now, back to my topic, approaches and access routes, and especially the decision algorithms for removal of colloid cysts. I have no disclosures for this talk. Colloid cysts, you all know, you are familiar with it. It's a rare disease. And if you look to the intracranial tumors, we see around about 2 to 3 a year. And we cover a population, neurosurgical population about of 1 million. The city itself is a little bit over 300,000, and the surrounding is about 600 up to 700,000 inhabitants. And we also see, respectively to the figure in the literature, 2 to 3 colloid cysts a year. Colloid cysts came from neuroepithelial tissue. You all know that the tela choroidea and the attachment is at the roof, mainly the anterior part of the third ventricle, but sometimes, and these are the sophisticated cases, it is not attached to the anterior part of the third ventricle. If it is attached to the internal veins and the fornices, it could give us some problems. And we have to discuss it, and we'll come on this topic further on. The colloid content is important. Normally it's a gelatinous material inside, and the protein ratio is also of interest because the consistency, you have a quite easy day and an easy surgical procedure if the consistency is very fluid and you can perforate the wall and suck out the low ratio gelatinous material. But if it is hard and dense, then it could create problems. We will see it further on. We all know, and it's a rare incidence, that those cysts can create occlusive hydrocephalus. We have 2 cases of these incidents, and we'll show it to you later on. And Pollock described that the natural history, it's a benign lesion, but sometimes, really sometimes, but rare, they create occlusive hydrocephalus, and this is an emergency situation. The decision-making, how to perform your approach, how to perform the surgical strategy is a matter of discussion. You have to take into account the signs and the symptoms. As I mentioned, if the ICP is elevated, it is another algorithm for decision-making as it is in a routine case without any symptoms. And we have patients with temporary elevated ICP like a ventricle mechanism. And the size of the colloid cyst itself is of interest. And as I've mentioned, the content of the protein and the consistency is also could be problematic. You have to take into consideration the size of the ventricle. Therefore, you can measure it with a ventricular index. If they are enlarged, there is another decision-making process as in narrow ventricles. And also the radiological appearance is of interest. And you have to pre-assess the histopathology. And I will show you 2 cases or mention 2 cases who are rated radiologically as colloid cysts, but they are not. And take into account the anatomy of the corpus callosum. It's very important, and you can easily study it and see it in sagittal MR sequences. Take a look at this, measure the thickness of the corpus callosum. It's important for transcallosal or a transcortical approach. If you are afraid of postoperative epilepsy, and if you closely look to the literature, the transcortical approach, even the endoscopic approach, is related to an epilepsy risk. But the numbers, they seem, for my opinion, quite high. Transcortical approach with 50%, but the usual range is around about 10 to 15% for a postoperative epilepsy if you use a transcortical approach. Summarize the approach. This is our target area where the usual third ventricular colloid cyst is located. And the usual transcortical approach, you go into the ventricle and have the route to the foramen of Monro and then down to the third ventricle. The other thing is using an anatomical gap, the interhemispheric approach, anatomically nice, and also transcallosal. It's interhemispheric. You go through the callosum into the foramen of Monro and from there to the third ventricle, or go interfomical. I will show you we have just 1 case with an interfomical approach. I think it's a sophisticated approach and it's risky if you damage the fornices. It could happen that you damage them both, and this creates really severe neuropsychological deficit. Therefore, I'm reluctant for the interfomical approach. Another approach, especially you will see later on, is a transcallosal subchoroidal. You go through the ventricle, detach the tenia fornicis, detach the plexus, and then go inside and reach the third ventricle. If you look to the literature, I've worked with Christoph Ostertag in Freiburg from 1999 to 2001, and he does just 1 colloid cyst frame-based-stereotactic approach. I think if you closely look to the literature, it's from the 80s or early 90s. It's more or less out. I really don't know any neurosurgeon who goes in with a frame-based stereotactic surgery for colloid cysts. But it was written in the literature, and I've seen just one. And you can also go in, hope that the content of the cyst is very fluid and you can aspirate it. But I think if the cyst wall is dense and solid, you will get a problem just to perforate the cyst. You need sharp instruments for it. Therefore, I think the morbidity is not related to modern transforaminal approaches by endoscopes or microscopes. Therefore, frame-based stereotactic surgery in brackets, I think it's more or less out. What comes more and more into the focus is the endoscope. And endoscopical approaches, you read a lot in the literature. Henry Schröder from Greifswald, he propagated, but all others also. And if you closely look to the recent literatures, endoscopic resection is more or less standard. A quite nice paper, not focused only on colloid cysts, is from the Basel group, neurocognitive complication after ventricular neuroendoscopy. It is a very interesting paper, and it summarized over 2,800 procedures, and they found in the post-interventional neurocognitive evaluation, 2% have transient deficits and 1% have really long-lasting or even permanent complications. And memory impairment, like really like an Alzheimer's disease or retrograde amnesia or real severe psychiatric disorders are mentioned, and the pathomechanism is not definitively clear. Is it directly harm to the upper part of the fornix who can create this memory impairment? But normally it is impaired if you harm both fornixes. And it could be also be related to the irrigation fluid. The amount of the irrigation could be a problem, or even having problems by dissecting the colloid cyst and harm one of the veins, like the septal vein or the thalamus striata, or even the internal vein. But this you will see it in a postoperative MR if there is a severe vascular damage. But it's an interesting paper that neurocognitive complications are not as rare as we expected in ventricular neuroendoscopy. Now the plea for the typical microsurgical approach. Microsurgery, if you look to the papers, a little bit older, 10 years, 1 decade older, but they have still a huge amount of patients. If you look to the series of over 100 patients, and it's a standardized approach, and it is a routine access to heal these benign lesions. There are some papers focusing on endoscopy versus microsurgery from the BNI group around Robert Spetzler. They have randomized the 27, respectively 28 patients with the microsurgical approach and the endoscopic approach, and they found out that they have a higher rate of shunting, postoperative shunting, and a higher rate of infection in the microsurgical group, and they have more residual cyst, part of the cyst or recurrence situation in the endoscopic group. And everybody knows who is dealing with endoscopy, you are limited with your preparation. It's more pulling to the cyst and not a real nice preparation as you do it under the microscope. But the final conclusion of the BNI group was that endoscopy is as accepted as first-line treatment in those lesions and have a little bit smaller complication route all along. Shapiro from Indianapolis wrote a relatively excited paper, and he damned more or less the endoscopic approach, and he's a clear fan of the subchoroidal phonic-sparing approach, and his focus is total resection of the colloid cyst, and he reported a little bit dogmatic, cost efficiency is a problem with endoscopy, and also the conversion rate that you go in endoscopically and end up with a microsurgical approach. He also announced that 5% have a recurrency rate, also a shunting rate, and also mentioned an epilepsy rate around about 8%. These are arguments for him that his interhemispheric transcallosal subchoroidal approach is the right way to treat colloid cysts. I think he's partially right, but it is not black and white. We have some gray colors, and I will come to this further on by the algorithm and treatment planning. If your goal, as Shapiro mentioned, is a complete resection, you are more safe with a microsurgical approach. And if you are not really sure that it is a colloid cyst, then I prefer personally also the microsurgery, because we ended up also with one conversion. It was a ependymoma in one case and a pilocytic astrocytoma, radiologically ranked as colloid cysts, but they were real tumors, and I feel more comfortable to resect those lesions under microscope than under the endoscope. And it's a usual problem that the radiologist cannot really define the histopathological diagnosis. If you closely look, correlation of MR and CT findings, and colloid cysts have a little bit diffusion MR imaging aspect. There are a lot of tricks to use MR techniques to define, is it a colloid cyst or is it not a colloid cyst? Quite easy. Sometimes do a very old-fashioned CT scan. Look at these images. This could also mimic a tumor. I'm not sure. This is more or less typical. This is also more or less typical, but sometimes it's very easy. Do a CT scan, and if you see these high protein content of the colloid cyst, you are quite sure. Bleeding could be also a differential diagnosis, but in this a CT scan sometimes solve your discussion with the radiologist, quite easy. Now to the surgical planning. I mentioned the ventricular index and the value of the ventricular size. Sometimes we see those ventricular asymmetries, and it is a valve mechanism. It's proven by literature also, and we found this also in 2 of our patients. You see an enlarged right frontal horn. Here's right, here's left. It's a navigation image, and you see probably it is a valve mechanism and blocks the fluid dissemination in between both ventricular horns. This is published also in the 90s and 2008, and it is a pathology created by higher pressure in one side of the ventricular system. And this brings up the discussion, if one ventricular side horn is really enlarged, then it's sometimes easier to go in transcortically directly into the frontal horn, or use the transcallosal approach. This will be discussed later on. But the ventricular index is a marker for your approach planning and for your decision making. If you have a hydrocephalus and a huge, like this, enlarged ventricular system, do not go in transcallosally and interhemispheric, go in directly. This was one of those emergency cases with a long-lasting and emergency patient who has this cyst for many years, and then he has a bleeding inside of the cyst and came in with an acute hydrocephalus, and she had a really awful outcome. She was blind and has a severe neurocognitive deficit. Therefore, in those cases, in emergency cases with a hydrocephalus, go in transcortically. If the ventricular index is normal, then you have all possibilities. We prefer more the transcallosal approach. But very important is also the location of the cyst. Is it ventrally located? Is it more in the dorsal aspect of the third ventricle? This is very important, and you can depict it very nicely in the MR, especially in the sagittal and also in a coronal view. You can, with a 3T Tesla, meanwhile, it's quite adequately depict where the location, where the attachment of the cyst really is. And also take into account how huge and how enlarged is your foramen of Monro. The size of the foramen of Monro, you can also make some specific angulation and MR reconstructions. Closely look to the size of your foramen. This is very important for your approach planning. Also decide go in right or left. Surgical is individual handy is one aspect. As a right-handed surgeon, you prefer a little bit the right side, as left hand the other side, but right-left is not only dominated by your handiness, it's also dominated by the local anatomy. That's very important. Closely look to the venous system. In this case here, there is a clear predominant left-sided approach because you have some bridging veins, two relatively thick bridging veins on the right side, on the left side, and therefore it is clearly dominated on this side to take it as an approach. And very important, probably this is the key point of this presentation, is the planning of your trajectory if you go through the foramen. Transforaminal approach, we also plan it every time we plan it from inside out. It's an inside out access. We look where is, in MR imaging, where is the attachment of the cyst. This is step first. Then take the trajectory in mid of the center, in the center of the foramen of Monro, and then project it outside to the surface of the skull. And you will be astonished that you are far more lateral and far more frontal as you expected. If you typically go with an endoscope to the roof of the foramen of Monro and then inside to open up the third ventriculostomy, you're much more close to the bregma, you're much more in the typical position where a ventricular drain is coming in. And if you do this inside out access from the attachment of the cyst through the Monro up to the skull, you are far more frontally and you're far more laterally. But respect this and you will get much easier access to the cyst, especially to detach the cyst. It's much easier than you go it standardized by a routine access like a ventricular drainage. I will show it in the last case at the end of the presentation. We also use navigation systems. We all do these navigation guided. I think it's easier. And just a typical awful colloid cyst attached, not at the frontal part, it's attached in the mid of the third ventricle. And if you see these very narrow foramen of Monro and the attachment far behind, I think this is impossible to go transforaminal. Even with the endoscope, you will not adequately have a visualization, and we plan it therefore with a subchoroidal approach. And in some cases you can shrink a little bit in the transforaminal the cyst, or open it up and suck a little bit of the protein content out, but you do not really have a chance to take an adequate visualization. Even with a 45 angled endoscope, it is really, really difficult to go inside and detach the roof here in the third ventricle of the attachment of those benign lesions. Therefore, in those cases, I think a subchoroidal approach is adequate. Now, once more to the topic of bridging veins. MR angiography is standard. You don't need a conventional angiography. MR angiography, especially in the 3 Tesla mode, is adequate. And take into the consideration that the veins normally have a convex inflow into the sagittal sinus, and try to get your access route and your trepanations so adequately adapted that you have enough space to go down in the interhemispheric approach, and you can plan it adequately within MR angiography. Usually we go in precoronally, as I mentioned, right or left side. If the venous anatomy is inviting you for the right side, as you see, no very big bridging vein, go in here. And once more, this case I've mentioned, transforaminal approach, especially in very narrow foramen of Monro, it's a challenge, and it could be, or it end up in a harm of your fornix. Therefore, make a decision not to use a transforaminal approach. Then you go an interfomical or subchoroidal. This is absolutely the advice, especially in those narrow foramen Monros and in the attachment in the back of the third ventricle. Once more, adaption of the craniotomy is necessary. Once more, localization of the cyst in the ventricle, inside out, and plan your trajectory and end up much more frontally and laterally if you go transcortical as usual. And if you go if you go subchoroidal, detach the plexus, spare the septal vein, spare the thalamostriate vein, and go in. And especially do not harm the fornix, and you will find an access route exactly into the third ventricle, and you end up directly at the attachment of the colloid cyst, and then it's quite easy with a little bit angled instruments to detach the cyst and remove it. And just show here, if you open up subchoroidally the third ventricle, you have an access, even you see the outflow in the fourth ventricle. You have a really nice view if you have an approach here for 10 to 15 millimeters subchoroidally. It gains a lot of access, and it gains adequate exposure and room for manipulation and preparation, especially much more than through those narrow foramen of Monro's. Once more, summarize it: transcortical approach, interhemispheric approach, transcallosal, transforaminal, if the anatomy is adequate, interfomical, I will show it later on, or as mentioned in those cases with a located in the lower or dorsal part of the third ventricle, transcallosal subchoroidal approach. Now to the different strategies. You all heard that the positioning could be crucial. I'm trained to do it in a supine position, and I visit Robert Spetzler, and they do it in the other way around. I will show it later on. Also a discussion how to make the skin incision, do a curved one, do a skin flap, to a straight incision. I personally prefer a straight incision. It's quicker to the lesion and quicker closed. Also discussion burr hole, where, how many burr holes, you need 1, you need 2, you need 4. There are also different philosophies. And also the side of the craniotomy. Do you go over the sinus? Do you go directly to the sinus? What kind of instruments do you use? Do you go both sides? So you have the opportunity to look left or right side of the forks if you go interhemispheric. And how to open the dura, where and how. Now, just mentioned to the BNI strategy, they called it retractyless surgery. They positioned the head elevated and go in contralaterally. You have a nice access, and the hemisphere goes down. I say the Newton retractor, the gravity will pull it down, but you need a little bit bigger access. If you don't need, if you don't use the spatula, You have to make a little bit bigger or enlarged craniotomy for these approaches. And but it's a nice approach. Definitively, you have a nice access to both pericallosal arteries, and the entry point in the callosum is centrally. And this is, they do the burr hole beneath the sinus. I'm trained to do it directly on the sinus and do not enlarge the craniotomy to the other side. I'm doing the craniotomy directly on the sinus. There are advantages, disadvantages. We can discuss it later on. Once more to the different strategy. Michael Apuzzo propagated this supine position, head flexed 15 to 20 degrees. I think it's a quite comfortable approach, but I'm not agreeing with 4 burr holes, but it could be standard, but a longitudinal horizontal skin incision, I think it's adequate. And I will do 1 burr hole here and probably another burr hole here, but it will be cosmetically not so nice if you see it, especially if you have not many hairs as many men have it. Now the instruments for the craniotomy. A typical electric or pneumatic perforator. This is the old-fashioned style. I've done it in Georgia. You need really manpower to do it. Usually high-speed drill. Our Chinese partner hospital use this. You can buy it at Alibaba. Looks a little bit Texas style with a pistol mount, but I'm convenient with this perforator or with cutting burrs or diamond burrs to open up the small burr hole over the sinus. Meanwhile, in the last cases, we use ultrasound piezoelectric bone scalpel. It creates very nice cutting edges, and this is in an anatomical specimen, but I like it also in real anatomy. You see it in the short video here. You need a little bit more patient because a typical perforator works with much more power, but it is adequate. And it's propagated that this piezo surgery creates no soft tissue damage. And if you use it directly over the sinus, we have had some other experience, especially if you cut directly here over the sinus, do it at the last thing. And you see that the upper surface of the dura is harmed, and probably it's a user-dependent error. But if you do this exactly over the sinus, you will create or get a problem if you open up the wall of the sinus. Therefore, piezo surgery is not harmless surgery. It can also create problems by opening up the sinus. Keep this in mind. As I've mentioned, if you are over the sinus, do it as the last step, because if you open up the sinus first, you have all the cutting to do before removing the bone flap. Therefore, this is the last step, is the perforation over the sinus. But it's not only for piezo, it's also for any other surgical approaches. I'm trained to do it directly on the sinus, but you also find parasagittal, and shape and size is up to you. It's an individual and multiple variations. I think separating the dura from the sinus wall, if you have a specific curved dissector, it's quite easy and you are directly on the sinus. And as I've mentioned, if you have this situation, do the last cut, do really the last cut over the sinus as the last step. If you have a laceration of the sinus, you have to be ready with the rest of the craniotomy, like this. Now a little bit to the mentioned how we do it. We do it in a prone position. Head is 30 degrees up. Normally we do no lumbar drainage because you reach the corpus callosum, you can drain CSF there. I think it's an additional risk, especially if you have a valve mechanism or a quite huge colloid cyst. A lumbar drainage is, for my opinion, a risk factor. And we all do it navigation guided, and we adapted to the bridging veins. It's important we do a straight skin incision, 8 centimeter horizontally, and normally 1 or 2 burr holes around the bregma, mainly 1 centimeter, maximum 1 centimeter behind or directly on the bregma, and for 3 to 4 centimeter frontally, like this. Normally the size of the craniotomy, it's a little bit small, but it's adequate, especially if you open like a door, the dura, and do the dural flap to the medial side. And here with 2 burr holes, and also the same manner, opening up the dura medially and go in without any bridging veins. This you can expect if you closely look to your MR imaging. CSS relief, be patient, do not make a severe retraction, bring in some cottonoids or sponges, and very slowly preparate your approach. Open up the cistern, suck out the CSF. These are typical now on the left side because you don't see a severe bridging vein. And bring in a spatula, not to really retract, just to secure or to hold. And just gently open up the arachnoid. And then do a separation of the pericallosal arteries. Be careful, you see there is a local vasospasm due to the relatively strong manipulation of both callosal arteries. And then you have a really ebony-like colored corpus callosum. It's a very nice view, and there you can go inside. This is typical straightforward approach, interhemispheric. Just take a look to the anatomy. We have one case with the third pericallosal very thin artery. It's one of the exciting moments that there is not as in the anatomy book. Then do the lateralization also with a cottonoid or a roll of a sponge, and do a soft retraction in the depth, not with a spatula. And then the callosal opening by bipolar coagulation, and then you are inside of the ventricle. Be aware that you're on the right or on the left side. That's important. You will see it sometimes not very quickly. Now, if you go in and have an adequate foramen of Monro, then the complete resection of the cyst is an easy, straightforward procedure, like in this. Go in, open it up, decompress it, shrink it, pull it a little bit, swivel it a little bit out, and detach it with an angled bipolar under respecting the internal vein and respecting the frontal aspect of the fornix. That's very important. And sometimes if you have a real enlarged foramen of Monro, this is a very easy procedure, or more or less easy procedure. And you end up by detaching it. Be careful with if the septal vein or a part of the septal vein is integrated, it could happen, and do not harm the vein. This is the final result. You have a bright and huge view into the third ventricle. Once more, some problems. Problems with the interhemispheric approach. Sometimes you have these granulations, these arachnoids and sinuses. They can bleed and create CSF reabsorption. This could be the explanation if you open up very extensively, if you have a great and huge craniotomy, because in the literature it's mentioned shunt dependency. This could create it, or probably could be reduced if you do not extend the craniotomy and do not harm all these arachnoid granulations. Be aware that you have sinuses. Sometimes the sinus is here, but you have a venous bleeding from sinuses. It's possible. And be aware of atypical bridging veins. They can run really long-term inside the dura, and then penetrate the sinus. Be aware of those anatomical variations of the bridging veins, atypical bridging veins. Another problem could be irregular Falx gaps. We have it quite often. We have it in 8 cases. The Falx is not like the Falx. The Falx has really gaps and is open, and sometimes you have really adhesions at those. The arachnoid is not as in the anatomical books. Irregular Falx gaps will create problems with the interhemispheric approach. Also, the size of the Falx is relevant, but this you can see in MR imaging. Take a look. Sometimes you have a very short Falx, and then it could be a little bit bloody, especially due to arachnoid adhesions to go down interhemispherically. It could be an argument against an interhemispheric approach. Adhesions are an interhemispheric no-go. Some other problems. You have sometimes severe venous bleedings or even air embolism if the head is too high up. Then manage it, put on a cotonete on the sinus wall, take a temporary control, adapt the OR table. In case of severe bleeding, go higher. In case of air embolism, go lower. Just adjust the table to the CVP, to the pressure in the sinus. It's a swashing of the blood, then it will be perfect. And also inform your anesthesiologist about this if you have a huge laceration of the sinus. And then reconstruct it under continuous irrigation to avoid air embolism. Do not try to do a primary suture. Normally you narrow it and it's not stable. Use autologous or allogeneic material, use glue or films or some other materials, and cover it and reconstruct it more or less quickly if you have problems by laceration of the sinus. Another problem, interhemispheric, as I mentioned, bridging veins. And if you do not adequately adapt your craniotomy, and sometimes you have problems with preparing those veins, this is a size you can occlude, but if you are too far or too close to the SMA or even to the motoric area, be careful sacrificing bridging veins. If you have a swollen brain, something went wrong, but we have these conditions due to anesthesiological problems and a little bit of small hydrocephalus. It is the wrong way to go in interhemispheric, and you will end up with a contusion. This is an awful looking situation. Now the pressure is out, the colloid cyst was resected, but the initial approach was not the right. In those cases, you are much more better if you go in transcortically. The harm is much less as if you end up with such a contusion in a swollen brain. This was a wrong algorithm, a wrong decision making going in. During the last time, we also used the size Kinevo with the endoscope, and we have some nice views. If you have bleedings, you can inspect bridging veins. This is an insight you never have under the microscope, and we also use it if you go in transforaminally, just to take a look for 5 seconds or 10 seconds, just 30 degree backward or sideward, and you have an adequate visualization under the endoscope. We use different available devices for the transcortical approach. Some are on the market, some specula are on the market, or even you can use a spatula and navigation guidance going down. And I just mentioned one of our interfomical cases. And I think it is an optimal route if you have a predominant anatomical situation, especially in the cavum verge. If you have a velum interpositum, as in this young guy, then it's very easy. You go in interhemispheric, go through the cavum verge and preparate down through both fornices. The anatomy is really reformed, and it was really easy. It was a straightforward procedure. This is postoperative. You see the cavum is collapsed and the cyst is out. I think especially in those anatomical situations, if you have a cavum verge, then I think the interfomical route is perfect. Otherwise, I'm really reluctant if you have to preparate here. Sure, it is an anatomical space, but it's not easy to find sometimes. And the interfomical approach, for me, it's a really dangerous situation. Now come to the summary of this more or less prospective data evaluation. We have 37 cases, no stereotactic approach, as I mentioned, 11 endoscopy removals, 2/3 are microsurgical, and I've mentioned transcortical, transforaminal 7, transforaminal, transcallosal 15, it's the major part, and subchoroidal 3, and just shown the one case interfomical, I think especially in this velum interpositum or cavum verge as a nice anatomical situation for an interfomical approach. Now to the lessons we have learned. It is no standardized approach. Is this really a treatment algorithm? Every case is a little bit different, and every case has to be discussed, and the approach has to be simulated, has to be discussed, and has to be tailored individually. And take into consideration, plan it individually in the in-out trajectory, go from the attachment from the cyst through the Monroe to the skull if you do a transforaminal approach. And if the Monroe is too small or the cyst is located in the lower or dorsal part, then the transforaminal route is not the adequate route. Just show you a case from 2017, 4 years ago. Also with a valve mechanism, you see the bulged septum pellucidum and a huge frontal horn. We discussed go in transcortically or go in transforaminally. And very important is also to keep in mind and to assess the cognitive function. Our last 12 cases were extensively investigated pre and postoperatively because it's not a paresis and it's not a speech deficit. These are fine neuropsychological deficits the patient have due to manipulation of the fornix, due to irrigation. Therefore, a quite adequate assessment is necessary to have an adequate follow-up for the patients. And just a very technical advice is plug the cortical approach with a glue or with a sponge. Even if you do a small endoscopic approach, 6 to 10 millimeters, or if you do it microsurgically, if you go transcortically, plug it, and you will have a significant reduction of subdural hygroma and especially subdural hematoma if you have interrupt the connection from the ventricular system to the subdural space. Now, summarize the arguments for which surgical procedure. As I've mentioned, if the intracranial pressure is high, then use a transcortical access. If you do it endoscopically or microsurgically, it's up to you. But if the brain is swollen, if the ICP is elevated, do not go in interhemispheric. If you have a very thin callosum, long-lasting cysts with valve mechanism and sometimes elevated and sometimes normal pressure situations, they create a thin callosum. Or if it's an anatomical variant, then you can see it very nicely in a sagittal MR imaging. If you have a thin callosum, the transcallosal route is, for my opinion, the most adequate. If you have large ventricles, you can also discuss endoscopy, microsurgery, but large ventricles are really balloon ventricles, go in transcortically. It's very easy. If you have small ventricles, this is really a challenge. Really small ventricles I prefer microsurgical transcallosal approach because you have no room and no space. If you go in transcortical, it's a long way to the ventricle, and you gain not a real advantage if you come in from more lateral. Then transcallosal approach is the main adequate route, and it's for sure experience-based. And please do not use minimal invasive as a marketing tool for endoscopy. All these are, for my opinion, minimal invasive approaches and minimal invasive procedures. And endoscopy, it's another device like the microscope, but it's not routinely used with the term minimal invasive. I hate this, sorry for this. If you are afraid of epilepsy, then the only route is transcallosally. I've mentioned up to 50%. For my opinion, it's much too high, but we have a risk of 5 to 10%. And if you want to avoid the postoperative epilepsy, transcallosal approach is a point of discussion, then transcallosal. And if you have the situation as shown before, if you have a velum interpositum cavum verge, then the interfomical approach is really straightforward, is preformed by the anatomical situation, and it's much easier as usual. And if you have small ventricles, really small ventricles, and sometimes a small foramen of Monro, this is the most challenging situation, then you can end up with a catastrophe in endoscopy, but also in microsurgery. And therefore, the only way is to go in and do a subchoroidal approach. This is the only route you will end up with an adequate anatomy. Sorry, I'm just falling out. I mentioned just to show you two cases, and here's a young lady with mild symptoms. She was weighed and scanned for many years. The neurologist said, okay, it's a benign disease. You have sometimes headache and there's sometimes visual disorders who are signs of an elevated pressure. But this was the MR situation. You see, there is no occlusion of the ventricle horns. You see the colloid cyst in a typical localization. She was 34 years old. This was the T1 imaging. Everything looks nice. And after several months, she came in with an acute deterioration, headache, vomiting, and really neuropsychological problems, and also visual disturbance. And the CD, the emergency CD, shows ballonated ventricles and a huge increased cyst. And if you closely look, there is a small bleeding or a small bleeding part into the cyst. We demonstrated later on in MR, and we go in as an emergency situation, do a ventricular drainage and do MR imaging. Directly after the ventricular drainage, she improved. And this is a situation directly after. You see the right frontal horn was drained. The left has still a valve mechanism. And you see really the bleeding inside of the cyst, gaining huge size of the cyst, acute deterioration and acute situation concerning and bleeding inside of the colloid cyst. Once more here in the T1, you see a little bit of air bubble due to the ventricular drainage, and you see the blood. This was a pathological moment, the bleeding inside of the cyst. Once more here, 8 months ago, looks quite adequate, and this looks awful or even not so awful after draining the acute situation. What to do in this case? We go through our arguments and the planning algorithm. She has still an elevated pressure, but only on one side, probably endoscopy. take out the ventricular drain and go in with an endoscopy. This was a plan, but if you closely look, it's very frontally located in a narrow chamber and a narrow access. I thought endoscopy by removing the ventricular drainage is not an adequate approach. Just to show, we planned it under the navigation system. We just simulate the way how the ventricular drain goes in. This is more or less parallel. You will end up much too frontally. You will not have an adequate visualization. You will end up in a narrow ventricular horn, have no opportunity for adequate detachment of the cyst. Therefore, this plan was not realized, and we go in or plan an endoscopic or plan an endoscopic approach from the other side. This will be the angle through the horn, and my colleague do the surgery, and he said, okay, why not? It must be not so narrow. Why not to go in transcallosally? We will end up directly in this enlarged foramen of Monro if we come a little bit from frontally. And this was the plan we realized. It was done, you see, quite frontal approach. Here the opening of the callosum and the direct approach in the relatively enlarged foramen of Monro and the detachment of the cyst. This was 3 days postoperatively. You see still the little bit enlarged root of the ventricular drainage, and you see the transcallosal approach, and you see the completely resected colloid cyst. Just as an example, how to work with these treatment algorithms and with treatment plans. Just to summarize it, keep it in mind, it's always more or less the same target, and you have different routes to go in. Choose the right one. This is more or less the message. And these are arguments pro and con, against and for those different approaches. Keep them in mind, please. Thank you.
Thank you very much for such a wonderful lecture, Dr. Spectgar. I'm sure all the audience has learned from your experience. Right now, we have a few questions from the public. The first one is, in which cases would you not recommend resecting the capsule of a colloid cyst? Are there any, I imagine, radiological features to consider?
Yeah. The general goal is to remove the cyst completely. But if you have the impression that the cyst wall is dense and very hard, and do not let you mobilize it adequately, and it's stuck to the internal cerebral veins, then cut it. It's not a bleeding situation because the cyst wall normally is avascular or more or less avascular, and then you leave a small remnant on the roof of the third ventricle if you have a close contact to the cerebral vein. This is a strong advice. I forgot to mention it. Then not the goal complete resection. The goal, keep the function, keep the vein intact, is the main topic.
Thank you, doctor. There is another interesting question. Is there any recommendation for the choice in the solution to use for ventricular inflow during endoscopy? Any complications from significant CSF exchange with isotonic solutions?
I think it is a point of discussion. What kind of irrigation do you use? And I think in a ventricular stomy, you normally use not a huge amount of irrigation fluid, and the amount is quite small. But if you use it in tumor surgery, and if you use it especially in a situation you have a constant bleeding, then you have a lot of irrigation fluid, you have a high amount of irrigation fluid. And this could create problems. If you ask the experts in endoscopy, they are afraid of constant and continuous irrigation, especially due to those isotonic solutions. Yes.
Doctor, thank you. Another question is, what would you recommend for pre and postoperative cognitive evaluation?
There are quite simple boxes and some quite simple tests. Ask your neurologist or your psychiatrist, finger tapping, reaction time, like memory, just a very, very easy remember tasks for cards or for different sizes and colors. There are boxes who are standardized, and they need about 20 minutes preoperatively, and if they are routinely and normal, you need 20 minutes post-surgically. You can do it during inpatient period after 5 days or after 4 days. The patients are they like it to have a monitoring of their own neurocognitive functions.
Thank you, doctor. Another question is, if a normal or a small ventricle is a limitation for use endoscopy?
I think the enlarged ventricle is good for I'm not a real endoscopic expert. I'm a little bit reluctant if the ventricle is small, because if you have if you have a not adequately planned access with the endoscope, you have a pivotation around the brain, you will damage a lot of tissue far away from the target lesion. Therefore, a narrow ventricle is a challenge for endoscopic approach. Absolutely a challenge.
Okay, thank you, doctor. In asymptomatic, incidentally discovered cases of colloid cyst, what size do you consider it to be dangerous and will recommend prophylactic surgery?
You have to discuss it with your neurologist. If you have the impression that the cyst is more or less blocking the CSF pathway, sometimes we do these dynamic MR imaging, and you have only a slight impression that there is a valve mechanism. We meanwhile consider surgery, because it's much less problems to do an innocent benign lesion as to wait for a catastrophe or wait for enlarged ventricles with probably slight neuropsychological deficit due to chronic elevated ICP.
Okay, doctor, and the last question is it frequently required a ventricle peritoneal shown during the follow-up because of hydrocephalus?
You have just one case, also after transcallosal approach, with a slight hematoma, interhemispheric, a little bit subdural hematoma, and she developed the hydrocephalus postoperatively, but not directly postoperative. After 9 weeks, she had a elevated ICP, and we have also a little bit subdural hematoma, subdural hygroma, and probably the direct communication through the callosum, and a little bit too huge craniotomy and coagulation of these granulations could provoke the hydrocephalus. Yes.
On behalf of CN, I would like to thank you again, Dr. Spetzga. This has been a wonderful lecture. We are really grateful and honored for your participation in the 2021 IWBNC.
Thank you. And I hope to see you in Bogota or come to Karlsruhe.
For sure, doctor, for sure. Okay. Thank you very much.
Thank you. Bye-bye.
Have a good night. Bye-bye.
Thanks.
For all the audience, keep in mind this lecture will be able on our website starting next week. In a few minutes, we will have Dr. Egid Thomas doing his lecture, Medial Meningeal Artery Embolization for CSDH. To get the link for this upcoming conference, please follow the link pinned on the chat screen or check the program schedule on our website, cntools.com.